I want to introduce our moderator for today, Dr. Ann Peled, who is co-director of the Breast Cancer Center of Excellence at Sutter Health CPMC. She is also a surgeon and researcher and a breast cancer survivor. Dr. Peled, welcome.
Thank you so much, Twin. Thank you so much for hosting this again. I really appreciate you and the CHRC having us, and thank you everyone for joining tonight. We're just going to go ahead and get started. I'm going to introduce all of our speakers and we'll talk about how today's going to go. So we started this, it's probably been 5 or 6 years now, trying to do kind of a breast cancer, breast reconstruction, breast health kind of awareness day to really highlight some of the programs we have here at CPMC and some of our different specialists. Our program here in general is centered around our Breast Health Center, which is the largest breast imaging center in Northern California, with almost 45,000 imaging exams and procedures. One of the things I feel very fortunate to be a part of is our multidisciplinary program. There's the physician provider side of it, but we also have a number of really extensive support services and resources for people who are being screened for breast cancer or going through breast cancer treatment. And there's a true focus on community outreach and education. So again, we're incredibly happy to be partnering with the CHRC again to host this event, but they really do a number of pretty incredible events. And so definitely check it out and see things that will be relevant aside from breast cancer. I wanted to talk briefly about what it looks like for our patient care pathway. Some of you on the call may have gone through breast cancer. You may know people who are going through breast cancer treatment. And really, this is what it looks like for our process here. We are incredibly lucky to have a nurse navigator paired with all patients through the process. And many of our patients feel like they're their point of contact. They're the person who helps them figure out questions, and they're really there with them from start to finish. It starts with risk assessment and screening. This is where patients come in, they're getting screening mammography, they get a sense of what their breast cancer risk is. And if your risk is elevated, then you may be referred to speak with other specialists who are high-risk specialists, as well as potentially genetic testing and counseling. If you do end up being in a place where you receive a breast cancer diagnosis, we have all of the state-of-the-art tools to do that diagnosis. And again, the nurse navigator is going to specifically reach out to a surgical team, a medical oncology team, and get our patients set up to move quickly through the process. We do have a multidisciplinary tumor board. We meet breast surgeons, pathologists, radiologists, radiation oncologists, medical oncologists, genetic counselors, our support services, nurse navigators, and we all get together and make sure that we're keeping track of all of our patients who've been newly diagnosed, coming up with plans together, and making sure that no one falls through the cracks in the different parts of their treatment. We do offer the full range and spectrum of treatment. We have a full team here that coordinates very well, both in tumor board and outside of tumor board. And then finally, for survivorship, I always say to people, it's an incredibly wonderful time to be a breast cancer provider because we're able to get so many people through treatment and get out on the other side. And it's incredibly helpful to have a team who can think about survivorship issues and make sure our patients have a clear plan. I'm really excited to introduce our CPMC Center for Women's Health. This has been a new addition to our program. It's an incredibly lovely space. This is just one view of it, but if you haven't gone yet to get any breast imaging or check it out, there are some really beautiful spaces and rooms, places for getting wigs and massages, and each of the treatment rooms is really pretty incredible. So this has been a wonderful addition to our program, and I really think is such a better patient experience for people going through what can potentially be fairly stressful. For our program agenda tonight, we're lucky enough to have an amazing group of speakers. Dr. Nazia Jafri is one of our breast specialist radiologists. Dr. Joanne Edquilang is a fellowship trained breast surgeon. Dr. Wang is a breast medical oncologist, as well as very involved in our genetics program. And Dr. Walter Lin is a microsurgical trained plastic surgeon. We're going to try after each speaker's talk to do Q&A right after that so that it's still relevant, since the topics are all related to breast cancer and breast cancer treatment, but are different. So please send in your questions via the Q&A, as Twin mentioned, and we can get to each one after each speaker's talk. I also wanted to very much thank our sponsors. We're lucky enough to have both Sientra and Natrel, who make breast implants used in breast reconstruction, sponsoring this event again this year. So thank you so much. Lastly, we do this event every year on the third Wednesday of October, and that's because it's a national event, which is Breast Reconstruction Awareness Day. And while it's wonderful to be highlighting some of the parts of breast cancer treatment and cancer awareness, we also like to bring things up related to breast reconstruction. Unfortunately, many people are still uninformed about reconstruction options. There are significant disparities in access to reconstruction related to race, ethnicity, and socioeconomic factors. Many people don't know that actually coverage for breast reconstruction, whether it's for lumpectomy reconstruction or mastectomy reconstruction, is actually federally mandated. And so we do try on this third Wednesday of October every year to bring up topics around breast reconstruction, make sure that people know it's an option and to ask for it. So please go to our American Society of Plastic Surgeons page talking about breast reconstruction if you have any questions. And certainly Dr. Lynn and I are both breast reconstruction surgeons and happy to answer any questions as well. So with that, we are going to move on and we'll start with our first speaker, Dr. Jafri.
Right, thank you for the introduction, Anne. Let me go ahead and share my screen here. Okay. Just want to make sure you can see my first slide here. Okay, perfect. So hi, my name is Nazia Jafri. I'm one of the co-directors of the CPMC Breast Imaging Center here. And today we're going to talk about screening mammography, the what, when, and why. So I wanted to sort of for you to walk away from this talk with a couple, couple of main points, basically the history of screening mammography, the benefits, terminology. There's also a lot of controversy surrounding when to get screening mammography. And so I wanted to touch on that, when to start screening, how often. And then if we have a little bit of time, we'll talk about breast MRI as well. I know it's a sort of mixed audience of both providers and patients, and also just people in the community interested about screening mammography. So really my main take home point today is that screening mammography is recommended annually beginning at age 40 for the general population. And I'll sort of talk to you today about, why screening and beginning at 40 is essential. Screening mammography has been found to be the only breast imaging study that has actually been shown to save lives. So when I say that, I mean looking at sort of mammography versus ultrasound and MRI, really truly is the only study that has been shown to save lives. Something to note is that early studies looking at risk and prevalence didn't include transgender, gender expansive, non-binary, or intersex identities. And there's a lot of work being done there to sort of uncover what the risk is, because we do know that exposure to hormones can increase your risk of breast cancer. So let's talk a little bit about statistics first. I feel like, most of us know someone, whether in our family, a neighbor, or personally who've had breast cancer. It's very common. It affects 1 in 8 women in the US, and it's the most common cancer among women aside from skin cancer. We often talk about sort of lifetime risk of breast cancer. And so on average in the general population, women have about a 13% lifetime risk of having breast cancer. So in a lot of ways, that's actually good news, because it means the majority of women will not have breast cancer in their lifetime. The median age of diagnosis in the US is 62. And American Cancer Society, if you're interested in learning more about statistics, it has sort of it's a great website to sort of look at the different stats. And for 2022, I have to say the numbers really look staggering. About 287,000 new cases of invasive breast cancer will be diagnosed this year, and approximately 43,000 women will die of breast cancer. Breast cancer, however, when caught early, is extremely treatable. And routine mammography, which we refer to as, the 2D mammogram, and I'll talk a little bit about the different types of mammography. It's been around in the US since the 1980s. Prior to the introduction of mammography, the death rate from breast cancer was actually essentially unchanged for 50 years. And then when mammography was introduced, that death rate dropped by approximately 43%. So where are we now? I feel like I hear a lot from patients, that it feels like the breast cancer rate is rising. And that is actually true. Since 2005, the incidence of breast cancer has been rising very slightly, about 0.5% per year. There's a lot of work being done on why that is, whether it's environmental exposures, things like that. The death rate since 2006 has steadily gone down in older women. However, in women younger than 50, it's been stable. And so kind of going back to the main point of my talk about annual screening mammography at age 40, that's why I think it's essential. We know that earlier detection saves lives, and treatments have significantly improved in the last 5 to 10 years. And so detecting a breast cancer on mammography it really improves outcomes. Most facilities are moving to the 3D mammogram compared to the 2D mammogram. And I'll talk a little bit about that. 3D mammography is also referred to as tomosynthesis. So you might hear those words interchangeably when you go to get your mammogram. At CPMC, we offer all women 3D mammogram, and it's better essentially at catching more smaller invasive cancers. So if you've had a mammogram or if you haven't, I just wanted to show you some images of what it's like to get a mammogram. We essentially do two views, the cranial caudal view, which is sort of like that pancake view if you've had a mammogram done before, and then this sort of oblique view. And these are the images that we obtain that the radiologist who's evaluating your mammogram is going to look at. Compression is important as part of a screening mammogram. And the reason for that is that breast cancer creates a fibrotic reaction in the breast. And so it looks white on the mammogram. And what happens when you compress the breast is the background breast tissue will look normal, and that abnormality will stand out to the radiologist because of that fibrotic reaction. And that compression is kind of key to detection. So what's the difference between a 2D and a 3D mammogram? So really, when you go to get your mammogram, you might not even know that you're getting the 3D mammogram. What happens is this is a kind of exactly what happens during a 3D mammogram. Rather than the X-ray tube remaining static, it'll actually move around the breast in an arc. And so we acquire sort of slices through the breast. I'll come back to that in just a minute to talk a little bit more about 3D mammography. I did want to kind of touch on COVID's impact on screening very briefly. So COVID really impacted preventative medicine in general, and the mammography numbers are really staggering. Nationwide, there was an 87% drop in mammography from February to April 2020. And misdiagnoses because of that occurred in about 36,000 women. Here at CPMC, we launched a return to screening initiative, not just for mammography actually, but other preventative studies, preventative screening such as colonoscopy as well, reaching out to providers to sort of remind their patients to come for their mammogram. So going back to that point about what is sort of the 2D versus 3D mammogram, like I mentioned, CPMC offers 100% 3D mammography for all patients, also referred to as tomosynthesis. When tomosynthesis first came out, a lot of people felt that it was really better for women with dense breast tissue, but we're finding it's actually better in all tissue, so whether you have dense breast tissue or not. The advantages are it's better at finding smaller invasive cancers, approximately 35% more. It decreases the recall rate over time, so being called back for additional images actually is reduced when you have tomosynthesis. It's also better at detecting masses and architectural distortion. And we'll talk a little bit about architectural distortion, which I'll show you actually a diagram here. So the first 400 patients that had tomosynthesis, it was actually patients who had had a normal routine screening 2D mammogram, and they went back and had their tomosynthesis done. And they actually ended up finding 7 patients who had a normal screening mammogram. 7 patients had breast cancer, only detected on tomosynthesis. And this is a diagram. You can see here's the 2D mammogram. There's a little bit of white tissue here. It doesn't look like anything much, but then you do the tomosynthesis view and you can see this sort of spiculated star appearance that's very classic for what we see for breast cancer. In this patient, she actually had 2 breast cancers in the same breast. And here's her surgical specimen or her lumpectomy, and you can see the 2 cancers next to one another. So why is tomosynthesis better? I'll show you a little diagram here. So on a regular 2D mammogram, we're limited by something called anatomical noise. And what does that mean? So breast tissue is essentially white. And like I mentioned before, cancer appears white on your mammogram too. So we're looking for things, architectural distortion, low density objects such as masses. And it's sort of, as you can see from the schematic, it hides in that breast tissue. Another thing that we look at on a mammogram, and you may have been called back for evaluation of before, is calcifications. The thing about calcifications is we can detect them whether it's a 2D or a 3D mammogram, but the majority of calcifications, about 85% of calcifications, are benign. So really 3D mammogram is helping us catch these sort of architectural distortions, these masses, and I'll show you a diagram of that as well. So here's a 2D mammogram. You can see there's this white patch of tissue, could be something, may just be breast tissue. And then you do the 3D mammogram and you can really see that this has margins. This is a mass. This actually is a cyst under ultrasound, but the margins are much better delineated on a 3D mammogram. Here's a breast cancer side by side, 2D and 3D. So again, you can maybe say that there is a mass here, but really hard to tell. Whereas on that 3D, it really pops those sort of spiculated irregular margins. So improves the detection of masses. So moving along, I wanted to talk with you about the controversy about when to get mammograms. And there's a lot of differing recommendations out there. So where did that come about and how did that happen? So in 2009, the U.S. Preventative Services Task Force published essentially information saying that annual mammography should begin at age 50, and then women should have it every 2 years until 74 and then stop. The American Cancer Society kind of wanted to fall somewhere in between because we had this original recommendation of annually at age 40, and they wanted to find a hybrid approach. So they recommended starting at age 45, doing a mammogram annually until 54, then every 2 years from 55 to 84. But they did say that most women should start at 40. So here you can see it's already very confusing. The National Comprehensive Cancer Network, American College of Radiology, Society of Breast Imaging, and most of the academic institutions in the US still recommend annual mammography at age 40. And that's our recommendation here as well, mainly because it maximizes the lives saved from early detection. And how do we know that? So really by looking at statistics, 1 in 6 women will be diagnosed with breast cancer in their 40s. So if we were to begin mammography at age 50, there's this whole group of women that essentially we wouldn't be getting mammography and we wouldn't be sort of catching these cancers early. 3 out of 4 women who are diagnosed with breast cancer have 0 family history and are not considered high risk. So they wouldn't really be able to self-identify as, having a genetic risk factor or having a first-degree relative with breast cancer. So again, starting later, we would miss these women. One study actually demonstrated that mammography cuts the risk of dying from breast cancer nearly in half. And we do know that premenopausal breast cancer, which is the type of breast cancer women in their 40s get, tends to be more aggressive. So those sort of U.S. Preventative Services Task Force guidelines that I mentioned to you will actually miss 1/3 of cancers and result in approximately 6,500 to 10,000 additional breast cancer deaths annually, which is really staggering. This is quite powerful to me. The federal government has actually barred Medicare and private insurers from basing mammography coverage on those USPSTF recommendations. We also know there are ethnic and genetic risk factors that differ among different populations. In particular, Black women have a higher incidence of breast cancer below the age of 45 and higher rates of aggressive breast cancer. So it really points to the strength of really doing annual mammography beginning at age 40. We don't have a lot more time, but I did want to touch on breast MRI. Breast MRI is our most sensitive imaging test for detecting breast cancer. And I often tell patients breast MRI is really good because we see a lot of stuff, and it's also really bad because we see a lot of stuff. And what I mean by that is the specificity is low. So it's about 80%. So there's a problem of false positives on an MRI, meaning you may have an MRI that's read as normal. You'd have to come back to us for an ultrasound, undergo a biopsy, and generally those biopsies are benign. That being said, breast MRI is really exceptional in sort of the high risk population. I think Dr. Edquilang is going to talk a little bit about risk assessment. If you are high risk and are undergoing annual breast MRI, prior MRIs are going to help with accuracy. So on your first MRI, it's very normal to be recalled for additional ultrasound or biopsy. But as we have prior MRIs, we can compare and say, this has been stable. And so the specificity actually improves as you undergo more MRIs. It is useful in conjunction with mammography for high-risk patients. And in terms of who's high risk, I think Dr. Edquilang is going to touch base on that. But essentially, if your risk is greater than 20% in your lifetime, BRCA carriers, if you have a personal history of breast cancer. It can also be useful in extensive disease planning. So if you're newly diagnosed with breast cancer, it's a good way to sort of measure how much disease there is in that breast and also highly screen the other breast. It's also really good at looking at the response to neoadjuvant chemotherapy. So that's chemotherapy basically given to people before surgery. It's also really good at looking at recurrence. So for example, if you've had a prior lumpectomy before and are feeling a lump at the site of your prior surgery, and the mammography and ultrasound are normal, it's a good problem-solving tool in those scenarios. And then, as Anne mentioned, I'm here at the CPMC Breast Health Center. We have 2 campuses. Our radiologists cover both campuses, one at the Pacific Heights Outpatient Center, which is on Buchanan Street. And then our other center is over at the CPMC Mission Vernal campus. We offer 3D mammogram to everyone at both of our facilities and also the newest biopsy technology. So definitely come and get your annual mammogram. And that's all I have. So thank you.
Thank you so much, Dr. Jafri. Really appreciate that. We actually have a ton of questions already, which is fantastic. Thank you, everyone. I'm going to try to kind of divide them up so that we can give them to each of the appropriate speakers. So Nazia, can we start with, for you, one of the questions is about how do you screen for breast cancer if implants are present?
Okay, that's a really good question. We would do a screening mammogram. So when you here at CPMC, we do 3D mammogram for women with implants. How it's done is we do views 2D with implants in, and then we do what's called an implant displaced view, where the technologist pushes the implant out of the way and we obtain the 3D mammogram. I think 3D mammography is a great screening tool for women with implants. And so essentially routine mammography.
Perfect. Thank you. And then another question, I know you talked a little bit about 3D mammography and MRIs, but I get asked a lot, about anything else coming down the pike. And there's a question here about any new imaging technologies that can be used to better identify breast cancers in difficult to interpret mammograms. So I know certainly sometimes we get asked about screening ultrasound or contrast enhanced mammography. And I just didn't know if there anything else you think coming down the pike that would be helpful for everyone to know.
Oh, yeah, no, that's a great question. Something we've been looking into here at CPMC is ultrasound, essentially. So in our practice at CPMC, I would say we're very generous with ultrasound. And what I mean by that is if you're called back, for example, for an asymmetry, we take additional views. We will often take our patients to ultrasound to sort of double check that area. So we use targeted ultrasound here very widely. There is automated breast ultrasound, which is basically what it sounds like. It's essentially a machine that's placed on the breast by a technologist, and you obtain essentially a whole breast ultrasound. And then the radiologist reviews it at another time. If there's areas of concern, the patient may be brought back for additional ultrasound targeted to that area. We don't offer that currently at CPMC. The reason why we haven't offered it is it does result in quite a few biopsies, and most of those biopsies are benign. So often it can put patients through a lot, and we're not necessarily catching more cancers that way. It is, however, something we're considering introducing here. Perhaps next year. I'm starting to look into the numbers. So it's a really good question. In terms of my personal opinion about it, I have mixed feelings about it, I'll be honest. I do think we often see things under ultrasound that are benign, and biopsies are minimally invasive, but if you've been through a biopsy, it's also, it is anxiety provoking to have a procedure, wait for results, And again, generally most breast biopsies are benign, particularly in people who are not feeling a lump. And so I am divided about my opinion on it. That being said, ultrasound is not very invasive. And so I think it can be a good option.
Perfect. Thank you. And then the last one is, once you've been diagnosed for breast cancer, do you always do a diagnostic mammogram? Is there any time that you can stop getting diagnostics and go back to screening?
That's such a good question. We've actually been reviewing that as a group of radiologists currently. And, different practices do different things. In our practice here at CPMC, we generally have kept patients in sort of that, like you said, that diagnostic imaging pool. So where we look at the images while a patient's here. I would say, in the first 5 years after having breast cancer, I think it's really important to have a diagnostic mammogram, because in those 5 years, the recurrence risk is highest. After that, it is optional. I would say our practice here has been to just continue it for as long as a patient wants to. But I think it's reasonable after those first 5 years to think about going back to screening. Some of it, I think, honestly, is a personal preference. If you're the type of person who feels like you do want to have your results and perhaps maybe meet with the radiologist after to talk about the results, I think doing a diagnostic is the way to go. And, in certain scenarios, when I'll look at a mammogram, I'm happy that the patient had a diagnostic, because, for example, if there's a lot of scarring, for example, and we need the extra images, it's nice to have the patient here so we can do that rather than call them back. But yeah, I guess the take home would be the first 5 years, I think it's important to do a diagnostic, and then after that, optional.
Great. Thank you so much. Thank you for your presentation, and thanks for answering all those great questions that people have put out there. So we're going to shift gears a little bit, and some of the questions on here that people have asked will actually come in the next talk, which is by Dr. Joanne Edquilang. Again, she's one of our fellowship trained breast surgeons, and she's going to be talking about assessing breast cancer risk.
Thank you. Let me get my slides up here. And so, yes, my name is Joanne Edquilang. I'm one of the breast surgeons here at Sutter CPMC, and I've been asked to talk about risk assessment and risk reduction. And so here are my objectives for this talk. First, I'll be reviewing some common risk assessment tools we use in our high-risk clinic, and then we'll be talking about strategies for risk reduction, briefly touching on medications that we use for risk reduction, and then more in depth about what we as surgeons can offer for risk reduction. And so I have to say a big thank you to Dr. Jafri for her talk. It's very clear that advancements in imaging are saving lives, and both of our governing bodies, the American Society for Breast Surgeons, as well as the American College of Radiologists, recommends assessing risk for patients starting at age 25 to 30. And that's really to identify who may benefit from additional high-risk screening and risk reduction to minimize the morbidity and mortality of breast cancer. And so let's jump right into risk assessment tools. And these can be used by patients or providers. And so there are a ton of calculators out there, but since we're limited on time here, I'd like to talk about the ones that we most commonly use, and those are the Gale model and the Tyrer-Cuzick. And I'll touch very briefly on Ask2Me because I think it has a very specific use that I think is very interesting when we're calculating risk. And so the first is the Gale model. And the Gale model is one of the most popular and well-used models, and it comes from the National Cancer Institute, and it's available online, and so anybody can access it. It can be used in patients between the ages of 35 and 85, and so this tool is actually not applicable to our younger patients. It's used only in patients who don't have a cancer history, including in situ disease, and without genetic mutations. It estimates the 5-year and lifetime risk of breast cancer. And the main factors that we consider are prior biopsy, benign disease, atypia, age at first period, age at first birth, and then a family history of breast cancer as well, but only in female first-degree relatives. And so a limited family history. And so this is really the tool that I think is best for determining eligibility for endocrine prophylaxis. And so we're going to talk a little bit more about chemoprevention and medications. And so this is the model that we rely on most. The next tool that we have is the Tyrer-Cuzick, and this is the model that I use the most often. And it's available online, but you can also download it if you're seeing patients in your office. There's a zip that's available online that you can use, and it's easy software to use in your office. And this is based on the UK's International Breast Cancer Intervention Study. And the main factors are BMI, which impacts the risk for postmenopausal women, and breast density. And you'll note that both BMI and breast density were not factors in the Gale model. Age at first period, first birth, and menopause. Hormone use, genetic mutations, again, not used in the Gale model. And then prior biopsies, which includes benign disease, atypia, and LCIS, again, not in the Gale. And what's important about this one is that the family history that Tyrer-Cuzick uses includes a much broader family history than Gale, and it accounts for all of extended family. And so I think it's much more extensive. Overall, this is a great calculator. Here's how it's presented online. And I think it's really good, and its strength is in determining MRI eligibility. And so Dr. Jafri talked about that 20% risk that we use, and the NCCN and the American Cancer Society uses that cutoff of a lifetime risk of 20% to be determined by models that depend on family history. And so that's the real strength of Tyrer-Cuzick. Ask to me. So I wanted to briefly address this one because I think it's got a very unique strength. It's called All Syndromes Known to Man Evaluator, and it's really good at estimating risk for a patient with a known genetic mutation. And what's unique about this calculator is it provides age-adjusted lifetime risk for patients who are diagnosed later in life with a high-risk gene. And so, for example, the risk of breast cancer in a BRCA patient diagnosed at age 40 is very, very different from a patient whose mutation is found at age 75. And so our recommendations for risk reduction should reflect that. And so moving on to risk reduction, this is a huge topic, and I could easily spend the entire hour talking about it. But there's a ton of research out there regarding lifestyle modifications, weight loss, diet, exercise, alcohol. Unfortunately, we don't have time for that discussion today. And so I'll be focusing on risk-reducing medications, also called chemoprevention, and then what we as surgeons can offer with risk-reducing mastectomy. And so let me preface this discussion acknowledging that we are very fortunate to work with many excellent medical oncologists, including Dr. Wang, who's on this call. And I defer to their expertise in recommending these medications, but this will be kind of a brief overview from 30,000 feet from a surgeon's perspective. And so these are the most common medications and their associated trials. These trials have been around for a long time. And so I won't go into the details of each trial, but first with tamoxifen, they compared placebo to a 20 milligram daily dose of tamoxifen for 5 years. And what they found was a consistent benefit of approximately 50% risk reduction. And in the higher risk lesions like lobular carcinoma in situ or atypical hyperplasia, we see an even greater than 50% risk reduction. With raloxifene, we also see a risk reduction, which is less so in situ disease when compared to tamoxifen, but still very significant. And then there's been a lot of attention more recently with low dose tamoxifen, with a 5 milligram dose for 3 years instead of the 20 milligram dose for 5 years. And there is a risk reduction comparable to the 50% risk reduction we see with tamoxifen, but also with fewer side effects, which is why I think this is a very, very popular choice and becoming more popular. In our postmenopausal population, aromatase inhibitors like anastrozole and exemestane were compared to placebo, and they were also found to have a risk reduction of approximately 50%. So when do our medical oncologists recommend prevention for our high-risk patients? The NCCN recommends that chemo prevention be recommended when the 5-year risk by the Gale model is greater than 3%, or the 10-year risk by the Tyrer-Cuzick is greater than 5%. And they recommend at least discussing chemo prevention when the 5-year risk is modified by the modified Gale is greater than 1.7. The American Society of Clinical Oncology has similar recommendations. Again, they identified women who are most likely to benefit as those with a greater than 5-year of 3%, 10-year at 5%, and then atypia and LCIS. So that is what our medical oncology colleagues can offer in terms of risk reduction. And so what can we as surgeons offer for risk reduction? And the answer is risk reducing mastectomy. And so this is a little bit of surgical history for you all. This is a Halsted mastectomy, a radical mastectomy, and it's a procedure that really is no longer done, thankfully. As you can see, it removed the breast, the skin, all the lymph nodes, and even the chest wall, occasionally muscle and rib. And so fortunately, this would never ever be offered for risk reduction. And even in cancer settings, we're no longer in the business of deforming women. So this is really a thing of the past. So what does mastectomy look like in 2022? The majority of mastectomies offered in our practice are nipple-sparing mastectomies, even in cancer settings and certainly in risk-reducing mastectomy. All the breast tissue is removed, but the skin, nipple, and areola are preserved, very often achieved with incisions that we can hide under the breast at the inframammary fold shown here. And so this is a cartoon depiction of our goal with nipple-sparing mastectomy. And as you can see, all of the breast tissue is removed with painstaking care taken at the nipple to remove all of the breast ducts right up to the nipple. And what's left is really just skin. And the plastic surgeon can then reconstruct the breast with an implant or the patient's own tissue, so-called a deep flap or an abdominal tissue flap, and microsurgery to connect those blood vessels to vessels in the chest. And so I'm glad Dr. Peled mentioned Reconstruction Day. And so I think part of the reason for the increase in rate of mastectomy is that reconstruction has become very, very successful. And so I wanted to show some examples of our patients with their permission. And this patient had a bilateral mastectomy with direct to implant reconstruction. And this means she had surgery to remove her breast tissue with mastectomy, nipple sparing mastectomy clearly. And during the same operation, she had permanent implants placed. And you can see it's a very, very good cosmetic outcome. These two patients had deep reconstruction or the abdominal tissue flaps that we were talking about. So bilateral mastectomy with flaps, again, with excellent cosmetic outcome for both of these patients. And so I wanted to take a second to thank Dr. Brian Perrett for supplying these images of our shared patients. And so we know we can achieve excellent results with our high-risk patients, but who really benefits when it comes to risk-reducing mastectomy? In other words, who should we as surgeons be offering this to? We know that patients who have genetic mutations associated with high risk of developing breast cancer benefit from risk-reducing mastectomy. And this includes the BRCA1 and 2, the P53, P10, and PALB2. And these mutations are all associated with a greater than 50% lifetime risk of breast cancer. Patients who have moderate risk mutations, ATM, CHEK2, CDH1, NF1, these have a lower risk of developing breast cancer, but still estimated at 20 to 50%, so still some benefit. For these patients, the NCCN and American Society of Breast Surgeons, they do state that for the high-risk patients that we should be discussing and considering risk-reducing mastectomy, but for these moderate risk, there may be insufficient data without a strong family history to recommend risk-reducing mastectomy. We have the most data to rely on in our BRCA mutation carriers. And I put Angelina Jolie up there because she's one of the most famous people on the planet, but she was also very vocal about having had risk-reducing mastectomy for her BRCA1 mutation. And we saw the so-called Jolie effect, which was an increase in the popularity of this choice for risk reduction. So for patients with BRCA1 and 2, bilateral mastectomy provides the highest level of risk reduction, approximately 90%, and avoidance of systemic chemotherapy. And so the data regarding survival benefit is a little less clear. There's probably a survival benefit, but at least a decrease in breast cancer specific mortality for patients with a BRCA1 mutation. Survey data also have shown less cancer worry and high satisfaction rates in patients who have undergone risk-reducing mastectomy. And an important factor to consider that a lot of patients think is very, very important is the avoidance of high-risk imaging. Many of our patients undergo MRI and mammogram every 6 months, which can mean multiple biopsies and a lot of anxiety. And so that's also a benefit for risk-reducing mastectomy. So I think the bottom line with risk-reducing mastectomy is shared decision-making, establishing care with a provider in your high-risk clinic who can help you identify your values, your preferences, your treatment goals, I think is very, very important. And this is not a small surgery. It's irreversible, associated with some occasionally unfortunate complications, including bleeding, infection, implant loss, skin and nipple necrosis, chronic pain, decreased sensation. And so with that being said, I think we're still able to achieve very, very good durable results, especially in our high-risk population, especially in our high-risk genetic mutation carriers. And so we've seen great benefit. So this is some members of our team who run our high-risk clinic. We offer individualized risk assessment, high-risk screening, genetic testing, and counseling for risk reduction. And so we'd be very happy to see you. Thank you.
Great, thanks so much. That was a fantastic talk and super comprehensive. I'm just looking at some of the questions that we have here. It looks like we talked a little bit about PALB2 and CHEK2. Someone had a question. I really love that askme.org site as well. So for people on the call who do have questions, it's incredibly helpful, particularly with mutations we don't know quite as much about, such as BRCA. So one of the questions is about if breast cancer runs in your family, how soon should the youngest female start screening? And I think this is a great question that we get asked a lot, if you want to answer that.
Yeah, sure. And so it's really 10 years before 10 years before the youngest person was diagnosed. And so we see women in their 20s all the time. We see women in their 30s all the time. And we do offer, genetic counseling and taking the full family history. If you're not sure, we're still happy to see you to do a risk assessment and to see, just because you're coming into the high-risk clinic does not mean you're going to have an MRI that day. And so we can come up with a plan to do individualized screening.
Perfect. Thank you. That's great. And then the last question is about using Gale model versus Tyrer-Cuzick in terms of thinking about who might be a good candidate for chemoprophylaxis or where your cutoffs are. So any thoughts you have about different models would be great.
Yeah. So, I think the Gale model, that's the real strength it has in talking about chemoprophylaxis. I think that 1.7% risk yearly, that was really based on the Women's Health Initiative and the average risk for a 60-year-old white person. And so it has some limitations to other ethnicities, and it can over and underestimate based on different ethnicities. And so that's something to be aware of. And so very often we use both. But for chemoprophylaxis, that's really where the Gale shines.
Perfect. Thank you. So I'm going to tackle a couple of these before we head into our next talk. So one of the first one is about high-risk mutations and moderate risk applying to other cancers such as uterine. And the reality is with genetic mutations in general, different mutations do have different impact on different types of cancers, and different families have different risk of different types of cancers. So certainly if you are someone who has a mutation running in your family, really important to sit down with a high-risk specialist or a genetic counselor and get a team together, because many of these mutations do go hand in hand, not just with breast cancer, but with other increased risk of cancers as well. And so important to really get together, again, whoever you might need on your team for that. And then the last question, which I'm happy to answer, is about breast reconstruction. So it's a little off topic, but Dr. Lynn is talking about lymphedema and lymphedema management. So I'm going to tie this in with Dr. Edquilang's results around mastectomy. And it was a question about reconstruction advances for those who aren't a candidate for DIP flap or Goldilocks, who don't want implants and who don't want AFC, which is aesthetic flat closure. So there are a bunch of terms in there that not everyone is going to know. So really quickly, DIP flap reconstruction is using tissue from your abdomen, bringing it up to the chest. Dr. Edquilang mentioned this a little bit, and it's using microsurgery, meaning very small vessels getting connected to other small vessels to make a new breast. A Goldilocks mastectomy is where you're actually using your own tissue in your chest. It's kind of a newer term for people who don't want to go through the full surgery and recovery of a flap, but do want to still have some projection. And so we use the small layer of fat that everyone has underneath their skin to recreate a breast. And most people end up being a lot smaller, but it is an option. And then aesthetic flat closure is really primarily a term used for people who want to be completely flat, don't want to have a formal reconstruction, but we also want to make sure that we're not leaving people with strange contour deformities and irregularities and making their chest look unusual. So in terms of reconstruction advances, the question has actually really covered pretty much all of the opportunities for reconstruction we have right now. The only one I would say that isn't on there is the idea of using fat grafting. So if you're someone that wants to have a small bit of projection, doesn't want to have a Goldilocks or isn't a candidate, you could consider doing an aesthetic flat closure and then doing a small bit of fat grafting to add a little bit of projection. It is difficult to make entire breasts of large size out of just fat grafting alone. Also, if you're someone that isn't a candidate for a flap reconstruction, you may not have a lot of extra fat to use for fat grafting either. But I think that's one option we have. The next thing that we have coming down the road, hopefully in the next few years, is some options for scaffolds where your own fat can go into it. And that will serve well for people who might not be candidates, but we're several years out for that. And so I think with that, then we will move on to Dr. Wang, one of our breast medical oncologists, who's going to be talking about genomic testing.
Thank you, Anne. I'm sorry that.
It's okay.
Take your time. I'm going to answer a couple more questions while I have a little bit of time. So one of the questions is about insurance covering the cost of surgery, including cosmetic if related to breast cancer. And we don't usually actually think of surgery that's being done to the breast after a breast cancer diagnosis, fortunately, as cosmetic, which is a good thing. We think about it as reconstructive. So insurance companies are required to cover reconstructive surgery the way they would cover knee surgery. And so certainly that is something wonderfully in this country that we're able to have access to, and is a federal law. In terms of some other questions, a question about, is there a finding that there is a higher percentage for people of color not being offered or told of new trials available? And one of the things we do try to talk about, certainly here and in other centers during Breast Cancer Awareness Month of October, is unfortunately there are numerous disparities in breast cancer care in this country and the world. You heard some from Dr. Jafri about disparities and differences in screening, but certainly we are still working on trying to make clinical trials more diverse, and it's definitely an issue, unfortunately, across clinical trials throughout medicine. So without further ado, Dr. Wang, I'll let you take over.
I have a filter on, so you cannot see me very clearly, right? But that's okay. You don't need to look at me. It's too fancy technology for me, but let's move on. Thank you for inviting me to give this presentation. The topic is genomic testing breast cancer. It sounds kind of complicated, but it boils down to whether every woman when she gets a breast cancer diagnosis, it naturally come across her mind whether chemotherapy is needed. So to borrow it from Shakespeare, to do chemo or not to do chemo, that is the question. Let me start with a case. This is someone I saw more than 5 years ago, 57-year-old. At the time of diagnosis, she self-found a lump in her right breast. After imaging and biopsy, it showed breast cancer that's a little bit bigger than 2 centimeters. It's a high-grade invasive ductal carcinoma, and it's positive for estrogen receptor, progesterone receptor, negative for HER2 with a high proliferation index of 40%. There was a lymph node imaging that was suspicious, that was also biopsied, and it was also positive for breast cancer. She had a PET scan. The PET scan showed that the cancer in the breast itself and in the lymph node, but no evidence of distant metastasis. And she saw the surgeon first, and she could go ahead have the lumpectomy. But the surgeon also wanted to see whether she would benefit from pre-op chemotherapy. So she did see an oncologist who recommended 5 months of chemotherapy involving 3 different drugs, fairly heavy dose chemo drugs, and then to do lumpectomy. At the time, there was some data to show that if the chemotherapy given before the surgery didn't result in a pathologic complete response at the time of surgery, additional 6 more months of oral chemotherapy may be beneficial. Okay, and then she came to see me, and I said, well, in your case, maybe we should do upfront lumpectomy and then doing genomic testing using gene profiling with a test called MemmaPrint, and to consider no chemotherapy altogether if the test shows genomically the disease is low risk. So why did I make that recommendation? Because for a while, we know that breast cancer is not one disease, several different diseases. This is the classic paper published more than 20 years ago by doing genetic gene profiling of different cancer types and roughly divided them into 4 different categories: luminal A, luminal B, basal type, and HER2 positive. And this is the probability of patients still alive with time, 120 months, 10 years. So different genomic profile has a different prognosis. In reality, let me break it down into 3 big categories. One is the most common, estrogen receptor positive and HER2 negative, and then the next one is HER2 positive, whether it's estrogen receptor positive or negative. The third big category is negative for ER, PR, and HER2, so-called triple negative. So the most common is the ER positive, HER2 negative, accounts for about 65 to 70% of all breast cancer patients. And of those most common type of breast cancer, anti-hormone therapy, the endocrine therapy, is the main treatment. The chemotherapy question can be answered with more refined tests. And that's what I want to go over more. The first clinical trial showing benefit of chemotherapy was done in 1989. How long ago was that? That was more than 30 years ago. Okay, so in the past, we don't always use chemotherapy for breast cancer patients. The first test 40 years ago showed after surgery, if you don't take anything versus taking tamoxifen for those most common type of breast cancer, which I just showed in the last slide, you live longer. More people live longer. This is 14 years out, and there is about 4 or 5% improvement in survival. And then the next trial added chemotherapy to tamoxifen, and it is a further improvement compared to tamoxifen alone. The difference is between 88% to 92%. So it's a 4 percentage point improvement in survival after 8 years after diagnosis. What that means is out of 100 women with a similar disease, 4 out of 100 won't die because those 4 got chemotherapy in addition to tamoxifen. However, we do not know which 4 will benefit from chemotherapy after surgery. So what we ended up doing is to giving chemotherapy to all 100 women. That was, since 1989. A woman with breast cancers are great. They supported each other and supported each other to go through these chemotherapy. And remember all these, the Avon Walk, the Susan G. Komen Foundation, organizing all the activities for women with breast cancer and their families to support each other. This is for the chemotherapy, for the most part. And we offer chemotherapy based on how big the tumor is, whether it's high grade, whether there's a lymph node involvement. So for the example of the patient that I gave you at the beginning, for sure she would go through chemotherapy based on these clinical trial data since 1989. 15 years later, there is a test called Oncotype that looked at 21 different genes in each tumor, these more common breast cancers. And we found out that we can subdivide these cancers into low risk, intermediate risk, and high risk based on a composite score of these 21 genes. Notice here that more than half of these cancers are considered low risk by this Oncotype test. About a quarter is considered high risk, another quarter about intermediate risk. And the rate of spread at 10 years for the low risk is only 6%, 6 to 7%. For the high risk, the risk of spread, and when it spread, most people subsequently die after the spread, is about 30%. And then in addition, we showed, this is looking back from that study in 1989, where the tumor box was saved and went back to do the Oncotype on these patients, and in 2000, and looking at how many are still alive and correlate their survival with their Oncotype score. And this is the same curve that I showed initially of 670 tumors tested out of these 2,300 patients. The difference in survival, if you lumped everybody together, is 4%. However, in the low-risk patients, with or without chemo, no difference. In the high-risk patients with chemo, it is a huge improvement, which means we should only give chemo to a quarter of those patients, not to all of them, like we have been doing since 1989. This is another related study looking at the same patients but with node-positive disease. So that was a huge game changer since 2004. and so we started to do oncotype on a lot of these patients and trying to figure out which one will benefit from chemotherapy, which one can avoid chemotherapy. There's some limitations to do the oncotype because there's a quarter of patients with the intermediate score, which we don't quite know what to do. And the data from the earlier trial was mostly in the postmenopausal woman, and there's very limited information on the premenopausal woman. And for the node polyp disease, it was not a very robust study. Meanwhile, there was a separate study that was being tested and validated that's called the MemmaPrint. And that looks at even more genes, 70 different genes involving in the different behaviors of the tumor cells. And the Europeans did a study using the MemmaPrint. What they did is they divided patients into they call clinically low risk versus clinically high risk, and then they use the MemmaPrint to find out whether they are genomically low risk or genomically high risk. If there's a discordant, meaning that one is clinically high risk but genomically low risk, whether chemotherapy will be beneficial or not. I will skip the details, but to give you this, which is if the patient is clinically high risk, like the example patients that I give with a polyp lymph nodes at the time of diagnosis, it's a high-grade tumor, it's high proliferation rate. So every indicator says it's a clinically high risk. But if the tumor tested is genomically low risk, these patients were randomized, half got chemotherapy, half did not get chemotherapy, and they were followed for survival out to 7 years, and there's no difference with or without chemotherapy. That's the bottom line that was published in 2016. So the conclusion of that study showed 46% of women with early stage breast cancer and high clinical risk may not require chemotherapy if the genomic risk is low, based on this DNA test. So that's a refinement, that's another improvement upon the oncotype that has been available since 2004. This is 2016. So with my patient, she went ahead and had a lumpectomy, and it's a 2.6 centimeter tumor. 3 lymph nodes were taken out, 1 was positive, and the MemmaPrint showed it's a low risk. It's one of the low risk subtype called luminal A, and that's the MemmaPrint index number. And based on that study I just showed you, no predicted chemotherapy benefit. So the patient went on the adjuvant endocrine therapy with the anti-hormone pill. She remains disease-free as we speak, more than 5 years since initial diagnosis. And the current recommendation for such woman is to take the anti-hormone pill for 10 years. So, you know, American Society of Clinical Oncology had a guideline in 2017 regarding when to use MemmaPrint to inform chemotherapy decisions. One is, you know, if the tumor is estrogen receptor positive, 1, 2, 3 positive lymph nodes, if lymph node negative, but there's other features of clinically high risk, including poorly differentiated histology if the tumor is more than 1 centimeter, or a better differentiated histology, but the tumor is big, like 3 centimeters. between 2006 and 2010, we did further studies using the oncotype in a trial called Taylor RX. So we refined the criteria of high risk versus low risk oncotype recurrence score, and enrolled the patient with the recurrence score of 11 to 25. And if it's below 11, we had, sufficient data to show that no chemotherapy is necessary. If it's above 25, everybody got chemotherapy. And it's the middle one that was grouped together and randomized to no chemotherapy versus chemotherapy. Again, there's no difference between the two. Whether it's the invasive disease free or distant relapse free, there's you don't see daylight in between the two lines. And that's another, a readout. It was headline news in New York Times in 2018. Good news for women with breast cancer, many don't need chemotherapy. There's some caveats in that study, mostly for younger women, younger than 50. And then remember, we look at their recurrence score between 11 to 25. But for younger women, if it's less than 25, but between 16 to 25, there's some benefit from chemotherapy. And that's when, we get into a gray area, and that's a source of a lot of, herring and going back and forth. So the Taylor RX, the primary conclusion is for people with recurrence score 11 to 25, you don't need chemotherapy, but there's some benefit in women 50 years or younger with a high-ish recurrence score. There was a lot of criticism about, trying to draw a conclusion on women younger than 50 with a high-ish recurrence score, because the analysis was an unplanned exploratory subset analysis, not enough statistical significance, and everybody suspect the benefit from chemotherapy may be due to ovarian suppression from the chemotherapy, not the chemotherapy itself. And there are other controversies that I wouldn't go through. More recently, which was published December of last year, again, using oncotype tests in the node positive breast cancer. The Taylor RX was the node negative. In the node positive, we looked at recurrence score from 0 to 25 instead of 11 to 25. And looking at chemo, no chemo. Of all participants, chemo, 95% patients remain free of metastasis at 5 years. Without chemo, 94%, 1% difference. No, real statistical or clinical difference. In postmenopausal women, the numbers are exactly the same. In premenopausal women, however, there is about 3.3% difference. So the current recommendation actually says in premenopausal women, if the disease involve a positive lymph node, 1 to 3 positive lymph nodes, don't bother doing oncotype. Should treat, because there is a difference. It is a 3.3% difference. again, not everybody is automatically buying into this because the chemotherapy may just be offering ovarian suppression, not necessarily a direct benefit. So the ASCO came out with a new guideline in April of this year for postmenopausal women, whether it's lymph node negative disease or 1, 2, 3 positive lymph nodes, you can either use Oncotype or MemberPrint. And if the results show that it's a low risk disease, there's no chemo benefit predicted, and we should not be offering chemotherapy. For premenopausal woman, if it's a node negative disease, one can do Oncotype, and if the recurrence score is high-ish, we can discuss chemotherapy for about 3 to 4% benefit. If it's a lymph node positive, the ASCO actually says offer chemotherapy to everyone. Do not bother doing the Oncotype or MemberPrint. The caveats of this recommendation in the premenopausal woman is both the Oncotype, the two studies using the Oncotype were not designed to test whether chemotherapy can be replaced by ovarian function suppression. There were separate studies, namely SOFT and TEXT trial, showing that high-risk patients, premenopausal young women with ER-positive breast cancer, if we suppress the ovaries and give them an anti-hormone pill, they do much better than taking tamoxifen only. The difference in survival is somewhere between 7 to 8 percentage point. And those kind of treatment was not included in these trials. The MINDAC trial using the MemberPrint also did an underpowered exploratory analysis of the same study that I showed you earlier, and did again show that in women younger than 50 years has about 5% difference when the chemo was offered, but is it clinically significant? It's unclear, and the investigators pointed out further study is needed in younger women who might need reinforced endocrine therapy to forego chemotherapy. Reinforced endocrine therapy means in young women with breast cancer, we shut down their ovaries, make them postmenopausal, give them an anti-hormone pill instead of giving them chemotherapy. So here is my algorithm in 2022. If the tumor is a small one, low grade, ER positive, no MemberPrint or Oncotype. This is clinically low risk. No chemotherapy. These tests will not inform us about chemotherapy because chemotherapy is not beneficial. If the disease has 4 or more positive nodes, these are high risk disease, and that they should be offered chemotherapy. We don't need to do these molecular testing. And for women who are older, who have other problems, who will not tolerate chemotherapy, or who absolutely will not open to chemotherapy, we should not waste $4,000 to do these tests just so we know. For premenopausal women, younger than 50 years old, and clinically high risk, particularly with positive lymph nodes, I think MemberPrint has good enough data to show that if genomically the disease is low risk, chemotherapy may not be beneficial if the patient would undergo enhanced endocrine therapy, meaning ovarian suppression and plus the anti-hormone pill. And if not either this one or this one, then we can do either Oncotype or MemberPrint. That's all I have.
Thank you so much, Joy. That was incredibly informative. Really appreciate it. It was great when you did this the last time, and I loved the 2022 update. So thank you so much. I think for the sake of time, we're going to move on to Dr. Walter Lin. He's going to be talking to us about lymphedema and lymphedema management. Thank you, Walter.
Thank you, Anne, and thank you to the CHRC. I am Walter Lin. I'm one of the surgeons with the Bunkie Clinic. I'm also the chairman of the Department of Surgery across town over at St. Francis. And today I'll be talking about lymphedema and evolving microsurgical management. So let me share this here. Okay, all right. Is that showing up?
It is, thank you.
Okay, all right. Okay. So our team is a private practice group. We're based primarily at CPMC, but we're also affiliated with UCSF and Stanford. And we were founded by Harry Bunkie here, who's known worldwide as the father of microsurgery. So that is certainly one of our expertises. And lymphedema treatment happens to be one of the up and coming fields worldwide in microsurgery. And we happen to be at the forefront because of our expertise. And this includes the relatively new field of super microsurgery, which is manipulating vessels smaller than 1 millimeter. As you can see here, this is from one of my surgeries. The lymphatic is that lower clear looking one next to a very tiny blood vessel right above it. And I will go into this further in the talk. So I'll go over briefly the background of lymphedema, and we'll mention the evaluation, but for the sake of time, we'll go more in depth into the treatment options, and then we'll show some examples. And really one of my goals overall is to help spread awareness of the available treatments for lymphedema, because it is really one of the most significant survivorship issues after treatment of cancer. And it really does have significant physical quality of life and economic consequences. In the US, as in most developed countries, it's mostly due to cancer treatment, roughly affects 5 to 6 million Americans who have had lymph node dissection and radiation therapy. It can be common in breast cancer. Previously, when axillary lymph node dissections were very common, we saw it in 20 to 50% of patients, but fortunately that's now decreased to about 5 to 7% with sentinel node biopsy. After cancer surgery, it usually presents within the first 3 years of surgery, but in the literature, it's been shown to be as early as 30 days to 30 years after surgery. And then the progression and severity vary from person to person after that. Risk factors for developing lymphedema include removing more than 10 lymph nodes during node dissection, chemotherapy, and radiation therapy, and then interestingly, a BMI greater than 30 at the time of diagnosis of breast cancer. But unfortunately, losing weight after diagnosis did not decrease that risk. I think some of you are familiar with the symptoms. There's edema and fluid buildup within the extremity that causes swelling, that physically is heavy, and it causes pain, typically due to the stretch on the nerve fibers within the arm. There can be skin changes later on, and then the impaired function also decreases the immune system response in that extremity. And so that can predispose to recurrent infections. And combined, these do decrease the limb function overall. So one of my key points is to spread awareness that treatments are available. And so we'll go over that. So in order to understand what the treatments are, it's important to know a little bit about the background of the lymphatic system. This shows what normal functioning lymphatics should look like. They look similar to veins, but they don't have as many connections between channels, and they're not as able to compensate for damage as veins are. Within the body, you can think of lymphatics as basically like a system of very small drains, almost like French drains that just passively collect fluid. Those feed into larger lymphatics just below the skin, and then those help actively pump the lymphatic fluid back into the blood circulation, which typically occurs in the chest. It's important to note that normal body function requires a working lymphatic system. The lymphatic system moves around about 15% of the fluid throughout the body. The rest is through the bloodstream. And then this also has an important role in your immune system and fighting infections, and then also transporting proteins and hormones and nutrients. Lymphedema occurs when that system is blocked. As you can see here, we'll go over this more, but this is lymphatic mapping of lymphatic channel here that is then blocked. When that happens, the fluid sits around, called fluid stasis, and that causes the edema, that ends up activating inflammation within the extremity, and that causes the body to deposit fat and deposit scar also. And it's unfortunately a downward spiral, because once you have the inflammation, that damages the remaining lymphatics, so more fluid sits around and you get more inflammation, and it's a downward spiral. So all of the data around the world shows that early treatment does improve results. Fortunately, over the last decade, there have been advances in technology and technique that have permitted us to develop treatment options such as superfine microsurgical instruments here. This is superfine suture, much finer than human hair. We have high-powered microscopes. And then also one of the biggest technologies is the ability to, in real time, map out the lymphatics. And so these images that I've been showing in these slides are all what are called indocyanine green lymphatic mapping, ICG for short. And essentially we inject a special dye, and that lets us trace out the lymphatics. And what we like to see are these crisp lines that look like veins. And then what we're looking for are where there's a traffic jam, where the dye starts to leak out of the lymphatics and form a cloud. That shows us where the lymphatics are damaged, and that signifies lymphedema there. And here's another example here where we're looking for the traffic jam here. And then in this example that I showed earlier. And what we're really looking for is this transition here, because that tells us we're able to do something and fix it. So combined, these new technologies and instruments have allowed us to develop super microsurgery, which is sewing together things that are smaller than 1 millimeter. Again, this is a lymphatic. And we hand sew these using a high-powered microscope. And to give you a sense of scale, I've scaled these side by side. This is a lymph channel that I've sewn to a vein, and I put blue dye in it. And this is next to a penny. And then you can see the very fine micro suture and micro needle that let us do that. So we've incorporated these new techniques into our treatment pathway. And ideally, people should be referred as early as possible, just because of that downward spiral effect, just so we can get them into therapy. I won't go fully into the evaluation, but basically we make sure it's not other things like clots in the legs or heart failure. And then we run some tests to confirm the diagnosis. And then we start non-invasive treatment, which is typically compression garments, lymphedema therapy, decongestive therapy at home, and then we try to get a lymphedema pump at home. Unfortunately, there are limitations, and it's very time-consuming. Compression garments such as these are uncomfortable. They're really hot, especially on a day like today in the Bay Area. They can be expensive. The insurance coverage is variable. So these first-line treatments don't always work, and they're not always tolerable. So that's when we start to talk about surgical treatment. And our options there basically depend on the severity of lymphedema. The most useful scale is defined by the International Society of Lymphology, but basically it goes from no visible edema, but having symptoms, to having fluid dominant edema, to kind of scar and fat-based edema, and then end stage changes. And then our treatment options depend on the severity. And in general, those can be thought as physiologic techniques that help to restore some flow versus reductive techniques that just remove the scar and fat. So lymphovenous anastomosis bypass, LVA known as LVB also. These basically divert the lymphatics before they hit this traffic jam here. So we're diverting the lymph channel into the vein so that there's an off ramp essentially. This is what it looks like in real time. Before surgery, this patient, you can see the highways here hit a traffic jam, and then there's a giant traffic jam here. We ended up doing our lymphatic mapping. We identified places where we could build our off ramps. So we performed our LVAs here. This patient was undergoing chemotherapy, so had a little slower healing here with that scab. But after surgery, you can see that we were able to restore the flow, and the traffic jam was able to improve significantly. In general, this is well tolerated. It's an outpatient procedure. It's very superficial, similar to removing a few moles. Many patients have told me it's painless without the need for narcotics or even pain medications. And because it's so superficial, there's a fairly low risk of complications. This does require super microsurgical expertise and is only offered at a few places on the West Coast. We typically do this with 2 to 3 incisions along the extremity. Each one's about 2 or 3 centimeters each. In general, they heal and scar fairly well. This is what it looks like. We identify a lymphatic channel next to a vein, and then we hand sew these together, and then we confirm that they're flowing well using our special blue dye and our special ICG dye. And then in this video, you can see I'll massage the hand, and then you can see the lymphatic fluid traveling back into the vein. And that's our off ramp to get by the traffic jam. So applying this, many groups have started to do this prophylactically in order to prevent lymphedema after axillary dissection. Typically, it's just used in complete axillary dissection. And in general, the way that this is done is after the lymph node dissection is completed, we use a different dye to find the lymph channels that had to be sacrificed in order to remove the lymph nodes, and then we divert those into the veins up in the axilla there. Lymph node transfer is a more powerful but more invasive option. And in this case, we're taking non-essential lymph nodes from somewhere else on the body, and then we're using our microscope to reconnect the artery and vein to the affected extremity there. And here we're not connecting the lymphatics, but we think these work as basically a pump, and the lymph nodes drink the fluid and dump it into the vein that we connect. And we think that these have growth factors that help to grow new lymph channels. And then we're also bringing immune organs to the site of recurrent infection, if that's one of the concerns there. Unfortunately, it is a bigger surgery, and it does require an inpatient stay because it is a transplant from yourself to yourself. And with the bigger surgery, has donor site risks, and there are some subtleties with cosmetics, but it's more noticeable than the lymphatic bypasses. Here's an example of what that can look like. In this patient, she elected to have lymph nodes taken from under the chin, and even before she left the hospital, you can see all of the fluid that was sitting in her hand and forearm is now being drank. It's basically the lymph nodes drank it up. We have the return of wrinkles. Her hand no longer is swollen. We have wrinkles up at the elbow as well. And she was able to stop compression sleeves altogether 2 months later. The reductive techniques that we have typically are used for non-pitting lymphedema, or after we've maximized our results with our physiologic reconstruction. These are primarily done with liposuction through a variety of techniques. And then in very, very severe end-stage lymphedema, then we perform excision, which is fairly rare at this point. We'll often combine these techniques, and here's an example where we did both lymph nodes and liposuction. There's lymphedema here in the left upper extremity. We ended up doing 2 lymph node free flaps in the forearm and the arm, and then came back to remove the skin that we include with the lymph nodes, and then do liposuction as well. And so we were able to remove a significant amount of volume. The arm is lighter, it can fit in normal sweaters, and improve quality of life. So in conclusion, I'd like to remind everyone, lymphedema is not a penalty for surviving breast cancer. It can be treated. It's really underappreciated, and there are new treatment options available, and early referral, even if it's not for surgery, is key for management and preventing progression of symptoms. So I'm happy to chat more in consultation if anyone is interested, and happy to take any questions.
Thanks so much, Walter. That was fantastic. I know we're a little over time, but I actually did want to ask you a quick question that I think is really relevant. So if you're someone who already has lymphedema, what would be, and maybe you haven't been evaluated recently or it's been a while, what would be the best place to start? Would you want someone to come in and see you for evaluation? Would you want someone to go to a physical therapist first, talk to their oncologist? How would you recommend someone start getting to get treated?
Yeah, that's a great question. I think the first things in evaluation are making sure it's not something that we're missing, such as a DVT or other problems, infections. So I would say usually it's the primary doc or oncologist will get a ultrasound, and then they can refer at that point to me, and then I can do more workup and then get them plugged into lymphedema therapy. And then I've got a compression garment guy. We use them so often, and then so we have a workflow. But I would say after the basic, rule out the infection, trauma, DVTs, then patients can be sent over and we can chat more.
Perfect. Thank you so much. Because it's certainly something I remember doing lymphedema research as a medical student. And unfortunately, it's really an area I think that tends to be undertreated, underfunded, underdiagnosed, all sorts of issues. And so we really appreciate having your expertise here at CPMC, because it's a huge thing for patients to know that they can be comprehensively taken care of. So thank you so much. And for anyone who's on, certainly all of our information is available. If you do have any questions, you want to email any of us, I'm happy to do that. So I just wanted to thank so much to all of our fantastic presenters. You really showcased our program and everything we were able to offer here at CPMC so well. For everyone who joined, I hope it was informative. I hope you got a lot out of it from an education standpoint. And again, all of us are happy to answer questions. And then Twin, finally, thank you again so much for hosting all of us. We really appreciate your commitment to doing this every year and allowing for this education around breast cancer and breast health.
We are really appreciative that we had such talented speakers come and join us today.